All right. Sorry, guys. Much like the title, my baby has RSV right now, so I was up with a sick toddler all night, so I'm running a little slow and late this morning. So we're going to do some cases. They're all going to be, just the disclaimer, they're all going to sound the same. They're all going to be respiratory distress, but they're all going to be slightly different variations on the theme. And we're going to talk about the cases and talk about some diseases and calls in kids and how we can manage them. I have no disclosures. We're going to talk about PEDS assessment first. We're going to run through some respiratory emergencies and common pediatric issues. Do remember that difficulty breathing, respiratory issues are the most common medical cause of EMS activations and EMS calls, okay? So number one in kids by and far is trauma. And then number two is respiratory, number three is seizures, and number four is ingestion and tox of the top four things that EMS gets called for kids. So number one medical call is, of course, respiratory stuff. Counts for 20% of all pediatric hospital admissions. So you're talking about a lot of kids every year. Counts for well over $1 billion in healthcare expenditures. So this is a big common theme for us. And it comes with a lot of different varieties. Talking about PEDS assessment and remembering that as we think about our respiratory rates and heart rates and stuff like that, remembering vitals do vary by age, right? So a toddler is a little different than a 10-year-old as far as what their normal vitals are. I'll be honest, guys, I am not smart enough to remember this whole table. So here's what I tell people to do. Remember this middle row here, right? Because 1 to 8 years old covers a big swath of kids, right? That's a huge group. And if you remember what happens around those numbers, you can sort of look at a set of vitals and eyeball them without memorizing this whole table, right? So if you remember the number 25 and you say, okay, well, this kid is 6 months old, that number should be a little higher. Okay, now I know if that kid's respiratory rate who's younger is 50, I'm probably okay, right? So if you remember kind of this group here, and then remember that the number gets higher when you're younger, and then for blood pressure, the other direction, right? So this more like adults, number higher here as you're younger, higher here as you're younger, lets you really quickly kind of eyeball a set of vitals and figure out, am I in the right neck of the woods or not? Am I a good place or a bad place, right? So again, if I give you a respiratory rate or a heart rate of 110, and I tell you that this kid, you remember that 110 is kind of your number for this middle group here, and I tell you the kid's 110, but they're 16, well, that's a problem, right? We know that number should be a little lower. But if I tell you it's 120, but they're a 3-month-old, okay, well, that number should be a little higher than 110. I'm probably in a pretty decent area, okay? So it's an easy way to sort of eyeball a set of vitals without trying to remember this, you know, like 8x3 table, right? Because a lot of us have way better things to try and memorize. Remember when we assess kids, we talk mainly about the pediatric assessment triangle. I know this is something that we've talked about before, and it seems really kind of simple, right? This little three-legged approach. But honestly, this thing is our best friend for assessing kids. The reality is that kids only account for about 5 to 10% of EMS calls, and only about 0.1% of those kids are really, truly critically ill. And so like many skills, if we don't use it, it's really difficult to maintain. Okay, and so having a little 3-step checklist that we can remember to assess a kid and determine who's sick or not sick is kind of a big deal, because that's what we really want to know. We know how to treat sick people. We know that we can have a slow, easy ride to the ER for the not sick people, right? What we really want to do is not miss the sick kid. We don't want to be the people who roll into the ER kind of casual, like, oh, this kid is fine. And then the ER staff like descends on the kid because they're sick, and then we all kind of sit there and go, oh, right? So what we want to make sure is we don't miss the sick kid. And again, if we don't use it, we lose it. And so having a little 3-step checklist, an algorithm essentially that we can easily remember to assess those kids when we don't see them a lot, can help us make sure we don't miss things. So we'll run through this real quickly because I know we've covered it before, but appearance, how are they interacting? Are they awake and alert? Are they distractible? Are they strong? Are they like floppy looking? Work of breathing, this is obviously going to be kind of important today specifically because we're talking about respiratory stuff. But how can we assess breathing rate? How fast? Are they retracting? Are we seeing ribs with every breath? Are we seeing that kind of belly suck in underneath the ribs with those subcostal retractions? Are they nasal flaring? any kind of noises. Grunting is a real serious noise that you should always take seriously. Kids can do this weird thing where they make this little grunty, panty noise at the end of exhalation where you kind of go, And actually what a kid can do, because of their unique physiology, they can actually generate about 2 to 3 centimeters of water of PEEP by doing that. And so that's essentially a kid who's so sick they have put themselves on their own automatic CPAP, okay? So if you ever hear a kid that's grunting, that's someone you need to take seriously. It's a real late sign of significant distress. So if you think of respiratory distress as sort of a continuum, we sort of start with the kid who's breathing a little fast. Now I've got kind of belly breathing with that seesaw belly going up and down. Now I'm like retracting, right? I can see those ribs sucking in with every breath. Grunting is sort of the next step. It's sort of last stop before the Holy Land or the ET tube, whichever comes first. So if you see a kid who's grunting and breathing hard, that's a kid you need to take seriously because that's a kid who's in really late, really significant distress. And then obviously noises. Of course, not everything that makes a noise is a wheeze. We have sort of 2 squeaky sounds that we talk about in kids. We have stridor, right, which is sort of an inspiratory squeak. We associate that more with upper airway issues, right? Something like croup or upper airway obstruction from like foreign bodies because kids put everything in their mouth, right? And then wheezing, which is more lower airway, right? We associate more with bronchiolitis or asthma, right, in little kids. And so we tend to think of that. That tends to need more, not always, but usually more of a stethoscope, right? Because that lives in the lower airways. Whereas stridor, which is more upper airway, usually you don't need a stethoscope to hear that, okay? And it's more of an inspiratory squeak. And then looking last, of course, at circulation. Big thing for kids, of course, is cap refill. Skin temperature and moisture are great. Pulses are great, not just presence of one, which is always important to know, but also where can I find pulses, right? Because if I can get a pedal pulse in this little 2-year-old, you know, they're probably circulating pretty well. If I can only find a femoral pulse in the 2-year-old, we might not be in such a great place. Color, being blue is never good. I don't care who you are. Mottled is this lacy thing that kids get over their extremities. Where they're capillary really big in kids. One of the things it differentiates kids from adults and their physiology is that they have at baseline increased peripheral vascular resistance, and their ability to shunt blood is incredible. It's one of the few mechanisms they have to compensate for shock and for being really sick. And they do it really quickly and effectively. And so capillary refill, which I sort of poo-pooed when I took care of adults, right? Like it was a checkbox on the PCR. I was like, oh yeah, I was probably about 4 seconds, who knows, right? It actually is a really sensitive marker of how well kids are circulating and how sick they are because they so quickly and efficiently and effectively shunt blood. So you can actually learn a lot by just squeezing a foot of a little baby, okay? It's like a little 6-month-old, squeeze that foot, wait for that color to come back. If it's 6 seconds, you can probably quit counting and just start doing stuff. But normal is less than 2 to 3 seconds. And then this is a picture of modeling. So we talked about this sort of this lacy blue kind of pattern that kids get over their extremities as they start to shunt blood. So this is a fun picture I found online at one point. I'm really amused by the graphic. Some people are really graphical learners though, so it helps. But I love the little kid here who has like a blue hand and a blood pressure cuff and like poop blood everywhere. But it's just a graphical sort of representation of the assessment triangle. Is the kid unresponsive, not interactive? Are they floppy? So their general appearance. The breathing side, are they head bobbing, retracting? Are they noisy breathing? And then the circulation side, mottled, pale, cyanotic, delayed cap refill, obvious blood loss. All the things that we can kind of look at and kind of think about when we're assessing a kid. The idea being that if we've got all 3 of these down, we're a sick kid, right? 1 down, we're probably okay. 2 down, we're sick. 3 is a kid who's really sick. That's a kid who's shocky, who's heading for cardiopulmonary failure. And that's a kid that we know we want to treat aggressively, okay? So we're going to think about these kids today when we talk about these cases, as we talk about them, as we talk about their vitals, talk about their exams, we want to think of that in the frame of reference of our triangle, right? So we want to think what we want to do when we look at any kid is we want to look at them and we want to think about that triangle. We want to go, are they sick or not sick? Is this a kid who's really sick and heading for failure, or is this a kid who's just kind of sick, right? Because again, what we want to make sure is we don't want to miss the sick kid, all right? So case number one, you're dispatched to a 1-year-old female with difficulty breathing, right? Everybody's going to be a difficulty breathing today. I think I made them all females too, by the way, on accident. But arrive on scene to find a patient with significant respiratory distress. Had eggs for the first time this afternoon. About 30 minutes later, broke out into a rash, began having some difficulty breathing, has thrown up twice. There's her vital signs: little tachycardic, little hypotensive. SATs don't make anybody feel too warm and fuzzy, right? Cap refill's a little bit delayed. Fussy, difficult to consult, retracting, has wheezing bilaterally, has a rash, looks like that. So what do we think's wrong with this kid? Yeah, this one's pretty easy, right? So this is an anaphylaxis kid. Remembering that anaphylaxis is becoming more common, and we do see a lot more of it. So when we talk about allergic reactions, we tend to term them more hypersensitivity reactions. There's actually 4 kinds of hypersensitivity reactions you have. When we talk about anaphylaxis, we generally talk about type 1, which is what most people think about with allergic reactions. And that's where you get an IgE antibody that binds to an allergen, and then they cross-link to activate mast cells that release histamine. And that's why Benadryl works, because it's an antihistamine. And so that tends to be, when we talk about allergic reactions, type 1 is what we tend to think about. But there are some other ones out there. You can get, in fact, like contrast reactions really aren't a type 1 reaction. When people talk about being allergic to like contrast, like CT contrast, it's actually not a type 1 reaction. It's actually a type 2 reaction. And so different kinds of hypersensitivities out there, although type 1 is the one we tend to think about and we talk about the most. Food allergies are really common. They're becoming more common. They affect about 10% of people. The exact prevalence is really hard to kind of pin down, though, because there's people who obviously are allergic and identify as allergic, right, because they like anaphylaxis to stuff. And then there's people who go, yeah, whenever I eat tomatoes, I sort of get a little itchy, right? And those people really are allergic. They just don't really consider themselves allergic, right? So, people go, oh, whenever I eat peanuts, I kind of get a scratchy throat, And so people who are allergic to things but don't necessarily identify as, oh yeah, I'm definitely allergic to that food because, I don't need an EpiPen when I eat it. But they are. And so the exact prevalence is sort of hard because of the wide array of symptoms. It does appear to be increasing over the last 2 to 3 decades, and it's kind of been termed the second wave of allergies. So the first wave, you used to not hear about people having like hay fever and snotty noses all the time, right? Because everybody like worked in fields, right? And so the first wave was sort of the environmental allergies, right? All the kids who grew up in like the 80s and 90s had bad environmental allergies, which is like there's like 9 different antihistamines that have commercials on TV constantly. So this is what we kind of are terming the second wave of allergies, this increasing prevalence of food allergies. It does seem to disproportionately affect people in industrialized nations. The highest rate is actually in Australia, believe it or not, followed by the US. And using CDC data from 97 to 2009, increased from 3.4 to 5.1%. So it is definitely going up. There are a few foods that make up the majority of them: peanuts, tree nuts, fish, shellfish, eggs, milk, wheat, and soy. Some food allergies actually have a pretty high rate of resolution with age. So milk, most people actually will grow out of a milk allergy by 5 to 10, greater than 50%. Egg, approximately 50% by 2 to 9. And egg is actually an interesting one. There's 2 different proteins in egg. And so depending on which one you're actually allergic to, depends on how much egg you can eat, believe it or not. So there are people who can't eat like, scrambled eggs or egg, but can eat like cakes that are baked with egg. So it turns out one of the proteins denatures at a high temperature. And so depending on which one you're allergic to, some people can eat egg like baked into things, and some people can't eat like any egg at all. And so it just depends. Others have a low rate of resolution. Peanuts, very few people grow out of, and shellfish and fish are frequently persistent allergies for life. Remember that anaphylaxis is potentially life-threatening. This was a big deal probably about 10 years ago. There was a couple kids who like died of anaphylactic reactions in schools and stuff, and it became a big deal about getting like EpiPens in school for everyone and things like that. These can be fatal. And remember that it's not necessarily just the kid who's like struggling to breathe, throat closing. So, the kid who eats something, breaks out into hives, vomits, can't breathe, scratchy throat, sounds awful, is shocky. absolutely all day that's anaphylaxis. But technically anaphylaxis is defined as an allergic reaction or hypersensitivity reaction that involves two body systems, okay? So for instance, a kid who breaks out into hives and vomits has GI involvement and cutaneous involvement. And that is technically anaphylaxis, okay? We would call that sort of a moderate reaction, but it still is anaphylaxis, and we need to treat it as such. And so again, can result from that. That's what makes sort of the prevalence a little hard to define, right? Because if most people just get hives and vomit, but they take Benadryl and feel better, they don't necessarily identify themselves as, oh, I anaphylaxed, but they really did. And frequently we get these kids in the ER, mom brings them in because they're covered in hives and they've thrown up like 3 times, like, oh yeah, you need epi. And the mom's like, what? We're like, oh yeah, you do. And so remember, and the other thing to keep in mind is even though maybe they don't have trouble breathing or throat closing, if they vomited and they have hives and you guys get there within 10 minutes, that doesn't mean they're not going to progress, right? That's the other reason we need to treat those kids, even though they might not seem that sick right then. Was that a question or are you stretching, Wes?
No, I got a question.
Okay.
So we've had some questions coming on the chat box. With kids having increased peripheral resistance and shunning of blood at baseline, would any hypotensive kid benefit from push dose, which is 1 to 100,000? And then the follow-up was push dose epi for anaphylaxis instead of IM or in addition to it?
Anybody with, so if we're talking about hypotension as a result of anaphylaxis, then I would not necessarily start giving them push dose epi. We need to treat their underlying reaction, which we do want to give IM epi. Do not give push dose. IM epi, because of the way it's absorbed and the route, the pharmacokinetics of that, of the 1 to 1,000 IM, is significantly better and much, much, much better, actually. And so it is definitely the preferred route. Even if the kid looks stinking sick, IM epi is still your first go-to no matter what, period. Now, with increased peripheral vascular resistance and the question of should any hypotensive kid get push dose, I would say no. My first bet would still be fluid administration. Remember that when kids are in shock, the two predominant kinds of shock in children are septic and hypovolemic, with hypovolemic being by and far number 1. Hypovolemic not just from trauma, but from medical causes, because kids can actually kind of poop, vomit, fever, and like dehydrate themselves into a hypovolemia because of their low fluid reserves. And so the thing about both of those is that they are fluid responsive forms of shock. And they need fluid because kids are very preload dependent. And so we've got to tank them up first. Pressors, now we are starting to move to the idea of doing pressors earlier in kids. And so maybe after 2 boluses instead of 3, kind of depending on how sick the kid is. So I definitely think that, there is a role for them early on potentially, but it definitely would not be my first go-to, if that makes sense. They still need fluid most of the time. All right. Remember that it can result from any route of exposure too. So it doesn't just have to be something that's eaten. It can be inhaled or it can be dermal exposure too. Like we have some kids that are so bad allergic to peanuts, like if they stick their finger in the jar of peanut butter, they will start to have a reaction, which just sounds miserable to me because I love anything peanut butter. Anaphylaxis is under-recognized again because the symptoms can vary so much, but it does occur. It is steadily increasing in occurrence. Time between exposure and symptoms can vary from minutes to hours. So this doesn't necessarily have to be instantaneous, right? And especially the kids who this is their first reaction, it is sometimes a little bit more delayed because they don't have sort of the antibody load to react to that antigen the way that somebody who's anaphylaxed like 8 times has, okay? So the mean latency period, though, is about 1 to 30 minutes. The skin manifestations are usually the first to come out. So the hives, the rashiness, the itchiness, that's usually the first thing you see. And then they kind of progress from there. Airway involvement can be subtle. It's not necessarily that I can't breathe, I'm wheezing, my throat is closing, but it can be just as subtle as sort of a scratchy throat or throat discomfort. Sometimes we see these kids who come in, they're like doing this number with their tongue, like scratching at their throat essentially, and that counts too.
There a time frame? with the difficulty breathing, it's going to happen after this time?
No, so it's sort of usually within about 45 minutes or so, but it can vary a little bit. But usually it's within about 30, 45 minutes-ish. The other thing we worry about is what's called a biphasic reaction. And this is why we say that any kid who receives epi or takes their EpiPen always needs to come to the ER. Even if this kid got their EpiPen and looks like $1 million, that kid still needs to come to the ER. Because these occur in up to about 6% of children. That number was probably a little overestimated in a couple of those studies because they counted like return of the rash as being return as a biphasic reaction. In reality, we know the rash sometimes does start to come back. But the actual occurrence is probably more like 1 to 2%. But these are kids who will initially get better after epi, kind of improve, and then get sick again, okay? And the reason we worry so much about this 1 to 2% is because these kids get sick as stink. These are literally some of the sickest kids that I've ever taken care of in my career, are kids who have had biphasic reactions. The one example I give is a girl who was a teenager who really, really liked pistachio ice cream, but was allergic to nuts. So every year on her birthday, she ate pistachio ice cream and gave herself her EpiPen. Happy birthday. It worked until the year it didn't. And I will never forget, this kid came in, RPS brought this girl in, and I remember them walking by the desk in my ER. I saw the kid, looked over and went, oh, that kid looks fine. She got her EpiPen and looks great. By the time they hit the other end of my desk, I looked at that kid and went, holy crap. And that girl ended up, we intubated her. Gave her so much epi that she actually started having runs of VTAC. We had to load her with lidocaine, back off her epi. She dropped both her lungs trying to ventilate her. She was so clamped down. I had to put 2 chest tubes in her. She ended up living and walking out of the hospital. But the point is, these kids who have biphasic reactions are sick as stink, okay? Which is why we keep all these kids in the ER after they get epi for like 4 to 6 hours to watch them. So anybody who gets epi always needs to come to the ER. We sort of touched on this already. Treatment of anaphylaxis, oxygen, epi, 1 to 1,000 IM is the preferred first-line route. Obviously, if they're shocky, we want to give them IV fluids and fluid resuscitate them. Benadryl, IV or IM, the dosing for kids is 1 milligram per kilogram up to 50 milligrams. Albuterol if they're wheezing. A lot of these kids who have anaphylaxis, they can either wheeze from the anaphylaxis, but a lot of them also have underlying asthma too. Food allergies, asthma, eczema, they tend to all run together. And so treating their wheezing as well. And then EPI 1 to 10,000 IV for refractory reactions, or if they're like a pending arrest. So the kid that you've given an IM dose to, who's still just sick, who's circling the drain, who's looking like they're about to code, that's the kid you can go ahead and give some IV EPI to. All right, case number 2, 1-year-old female with difficulty breathing. Same thing. This time though, you arrive on scene to find the patient with significant respiratory distress, 4 days of cough, congestion, getting worse, saw their PCP on day 1 of illness, got diagnosed with a virus, got sent home with some breathing treatments, but they don't seem to be helping. Heart rate's 160, there's her vitals, you can read them. Alert, tired acting, thick nasal secretions, belly breathing with subcostal retractions and nasal flaring, lungs just coarse sound. You put your stethoscope on, sounds like she has a washing machine in her chest, and has some scattered wheezing. So what do we think is wrong with this kid? Has a virus, getting worse, day 5-ish. Any ideas? Thick, pouring snot. Yeah, perfect. She has RSV. Well, she has bronchiolitis, which is typically caused by RSV. The most common cause of bronchiolitis is RSV. There are some other viruses that cause the clinical syndrome that we sort of coin RSV. The number 2 most common cause of non-RSV bronchiolitis is actually non-COVID-19 coronavirus. There's been a really fun year when I have to explain to all these parents their kids have coronavirus, but not that coronavirus. And then also caused by human metapneumovirus frequently. So good. So with bronchiolitis is most common cause of hospitalizations among infants during the first 12 months of life. This is really common. 100,000 bronchiolitis missions occur in the US each year, accounting for $1.73 billion of healthcare expenditure. So we're talking about a big disease load here. It is a viral infection of the lower respiratory tract, like we just talked about, typically caused by RSV, but a lot of others, although every single child in the state of Alabama has RSV right now, I swear. Because I'm pretty sure I've seen them all in the ER. With RSV, it's a very stereotypical 5-day course. Kids get sicker, sicker, sicker. Day 5 is their worst day of illness. And then after that, they start to turn the corner and get a little better. With some of the other viruses that cause it, like coronavirus, human metapneumovirus, rhinovirus, it can be a little more variable, but typically we tell people just 5 to 7 days. Usually most commonly affects kids 6 to 18 months of age. They get a mild fever, cough, and then the congestion is really kind of the hallmark of the illness, right? These are the kids that sound like Darth Vader when you walk in the room, because they're just so full of snot, okay? And causes inflammation in the lower respiratory tract that can make them wheeze sometimes, even though they're not like asthmatic. Risk factors for severe disease: any kid who's less than 12 weeks of age, history of prematurity, chronic lung disease, sort of the things that predispose you to getting super sick for anything are sort of the things that predispose you to more severe disease and bronchiolitis as well. The treatment is really supportive. It's a virus, so antibiotics don't do anything. It just sort of has to run its course. We have to support their airway as needed. Suction, suction, suction. Suction is really the thing that fixes these kids in the end as much as we can. Because the problem is that babies are really obligate nose breathers. They do not like to breathe through their mouth. They really, really much prefer to breathe through their nose. And so when they get bronchiolitis and they're just pouring and full of snot, they really just can't breathe. And if you suck all that out, it helps their breathing, it helps their cough, and occasionally you get enough out that it helps their inflammation, and their wheezing gets better too. So suctioning is the most important thing, and it's really what takes. You would be amazed if you came and spent a day, especially right now when there's RSV everywhere, walking into the rooms of some of these kids that look awful with their breathing. My respiratory therapist goes in there and suctions them out really good, and I walk back in and they're like whole new babies, okay, that we end up sending home. It really is what fixes a lot of these kids, more than you can believe. If you don't have a bulb suction kit in your PEDS kit, I recommend you get one. But if you don't, and you don't want to break into your OB kit for one, you can actually just take like a little 10-French suction catheter like we use to suction out ET tubes, cut it off so it's like a couple inches long, stick it down their nose, and then suction on the way out. It'll accomplish the same thing. If you want to get really fancy and add some saline drops, go to town, because it actually helps a lot, helps break all that stuff up. Stick a little saline in one nostril, feed the suction catheter down the other, suction all that stuff out, and rotor-rooter out that nose and those sinuses. These kids look like whole new children, I'm telling you. Oxygen to maintain their saturations. Again, this does create like a viral pneumonitis. We talked about that inflammation in the lower respiratory tract. So sometimes these kids will be hypoxic and need some oxygen. A lot of times these kids can be pretty dehydrated too, so they may need some IV fluid and fluid resuscitation. Because when you're a baby, it's a lot of work to feed, right? Like feeding is exercise for babies. And so if you're sick and you don't feel good, you don't necessarily want to feed real well. The other problem is, what do you have to breathe through when you're feeding a bottle? Your nose. So what happens when that thing is all clogged up? You can't breathe. So if you can't breathe, you generally don't want to sacrifice feeding or breathing for feeding. And so a lot of times these kids just haven't fed well for a couple of days. They haven't, they've had like 1 or 2 wet diapers. And so a lot of times they're kind of pretty dehydrated by the time they get to the point that they're calling you and presenting to care, okay? So they may need a little fluid resuscitation as well. Albuterol is not recommended. So this used to be a thing, and a lot of like old school pediatricians still send all these kids home with like breathing treatments. The reality is that very, very few of these kids respond to albuterol. In fact, less than 10%. And the new American Academy Pediatric Guidelines for the treatment of bronchiolitis do not recommend albuterol for kids. They don't even recommend. We used to say, well, we'll try it, and if it works, then we can keep giving it to. They don't even recommend trialing it anymore. But that being said, it can be helpful in specific cases, anecdotally from a lot of PEDS docs since that came out. That recommendation is that really there are some kids that maybe do benefit, and it's generally the kids who have wheezed in the past, right? So if you're a kid who's recurrently wheezed, like, every time they get sick, doc, we have to give them breathing treatments. Those kids probably do have some underlying reactive airway disease or like early asthma, and so they might benefit from it. And so if it's a kid, definitely a kid who's had like recurrent wheezing before, it's definitely worth a shot, but don't freak out if it doesn't really do anything. Yeah, man.
Okay, so we had a couple questions come in. I think you just answered one, which was about albuterol. So the question revolves around the initial EMS training that we all get that talks about young children not really being able to develop asthma until they're toddlers. So is there validity to that? Can a young baby have asthma that would benefit from albuterol? And I think you kind of just answered that.
Yeah, so we don't diagnose. So what we call it when you're little is reactive airways. So kids have really hypersensitive airways. And so you can get like virally induced wheezing in kids that'll wheeze once or twice when they're little, but never wheeze again. And we don't like to call you asthmatic until you're older and have that recurrent pattern of wheezing that you're clearly not growing out of. And the biggest reason, honestly, is because if we label you asthma, if you go to apply to be a fighter pilot when you're 18, enlisting in the military, then you're automatically excluded because somebody labeled you asthmatic at some point. And so we don't like to label you asthma until you grow up a little more, because there is a chance you grow out of that recurrent wheezing and those hypersensitive airways. So until you're like 2 or so, we tend to call it reactive airway disease, which you can think of as asthma, but not asthma, or pre-asthma if you want to get fancy, I guess. So there are some kids who definitely have reactive airway disease, who will recurrently wheeze, who probably will be labeled asthmatic once they're older and have a more defined pattern, but we don't call them that yet, if that makes sense.
Okay, so the other question we got is pretty interesting. So other than the obvious equipment size differences, why is CPAP BiPAP not recommended for kids?
It is recommended for kids. So it used to not be. Honestly, there used to be this weird thing where they thought it was not good. It is great. I put a kid with bronchiolitis on nasal CPAP yesterday. I put a bad asthmatic on it last week. It works. It works really well. It is recommended for kids. The reason it ends up not being happening to a lot of kids is the equipment different. You have to size it really accurately. And it's really hard, especially in the pre-hospital setting, with the varying sizes of little babies, to get that equipment size. So you're making sure they're getting a good seal, and to carry, I'm telling you, to put a kid on I have like 19 different size CPAP masks in my ER, because you have to size it so specifically to the size of the kid to make sure that seal is happening. Most places are not going to want to carry 15 or 10 different, CPAP masks or little nasal masks. And so that's what creates really the biggest barrier to it. But it actually does work really effectively. And if you've got, like a small size mask and you got a bigger kid, by all means, try it, go for it. If they're, unresponsive to all the other treatments you're doing, and it's an older kid with asthma that, because obviously a bronchiolitic baby, you're not going to be able to fit like a small adult mask on. But, if you got an older kid that's like a sick asthmatic that's on Neb3 and had some IM epi and still looks like stink, by all means, put them on some CPAP. I don't care. Probably make them better if they'll tolerate it. A lot of kids don't tolerate it very well either. That's the other issue. All right, suctioning. So this is a regular bulb suction. You kind of occlude one nostril, push the bulb in before you put it in the nose. Otherwise, you're just blowing the snot back into where you want to get it out of. So squeeze it, put it in, and then let it go, and and that pulls out the snot. You got to make sure you occlude the other nostril. Ooh, that zooms. You can put some saline in that nose. If you got the little saline bullets, little pink things of saline, or just a little flush, drop a couple drops of saline in the other side, occlude it, and then suck it out. It'll roto-rooter everything. This is the nose Frida. I think this is the most disgusting thing on the planet. But my peds residents and some of the parents that I see swear by this thing. You put it in here and you just suck the snot out of their nose. There is supposedly a filter in here that stops anything from getting through. I personally don't believe in any technology that only costs $5 that much. And so if you want to try it, go to town. I think it's the grossest thing on the planet. That being said, my wife swore by it. Anyway, so sucking a kid, this is what we do in the ER. We have these little, they're called neomates, neomate suckers. And they're actually little, like, designed to go on the end of regular suction tubing and kind of slide down in their nose. And you can suction them out with wall suction. And they work really well too. And the kids fight like you would not believe. All right, any bronchiolitis questions? Okay. Case 3, 1-year-old female with difficulty breathing, arrive on scene. We got one more after this, so we're going to try and go through this one kind of quick so we can get to the last one. 1-year-old female with difficulty breathing, arrive on scene to find a patient with labored and noisy breathing, cough congestion for 3 days, or congestion and rhinorrhea for 3 days, cough starting yesterday. Today, the cough sounded more barky, and then tonight woke up in the middle of the night from sleep with noisy breathing and difficulty breathing. There's your vitals. Patient's fussy, inspiratory, noisy breathing with subcostal retractions. What do we think this is? Yeah, good. So here's I don't know if the video will work. We'll see. Half the times these work, half the time they don't. Ooh. Yeah. All right, well, apparently the sound will not work. Or at least it's not in here. Is it working on like, kind of maybe? Anywho, you guys figured it out anyway. Oops. All right, so this is a kid. Yeah, somebody said it perfect with croup, right? So croup's a viral illness. It's typically caused by parainfluenza virus, which is not the flu, just sounds like it. Usually occurs in kids 6 months to 3 years. So adults actually get this all the time. We get paraflu, and it's no big deal. Paraflu causes some swelling in the upper airway. So when you're a big grown adult with a big grown, well-developed airway, a little bit of swelling doesn't really make a big difference, okay? We get sort of a scratchy throat and an annoying cough for a few days, and then we get better. We essentially think we have a cold, which we do. But when you're little and you have a small, not so well-developed airway, that little bit of swelling goes a long way. Think of the difference if you pinch a garden hose versus if you pinch a McDonald's straw, right? Big difference in the kind of flow you're still going to get through that, all right? And so that's the same concept. Because these kids have smaller, less well-developed airways, that little bit of swelling makes a much bigger difference for them than it does for us. And that's why it usually generally occurs in kids 6 months to 3 years. But we actually see it in some older kids. You can see it up to about 6 years of age, but becomes definitely less frequent. Peaks in winter to spring, and accounts for about 15% of peds ED visits for respiratory distress. So usually associated with a barky seal-like cough with a viral prodrome. So again, you normally get that. We've had 3 or 4 days of congestion, then the cough started, kind of sounded okay at first, and they got really harsh and barky sounding. Piece of trivia, they call it a seal cough, like seal barking. Seals don't bark, only sea lions. Anyway, just as an aside. But if you read any medical textbook, it will call it a seal-like barking cough. Telling you. All right, usually accompanied by a viral prodrome, and it does tend to be worse at night. So always the parents come in, these kids wake up in the middle of the night, trouble breathing, stridor, always in the middle of the night, and usually are like, look great by the time they hit the ER, and parents are like, I swear he looked awful. And there's a lot of reasons why they get worse at night and are better by the time they get there. First off, they're laying flat, and so that allows that swelling to get worse. Second, your body's own endogenous steroid production goes down at night, and so that allows the swelling to get worse. And so they do tend to wake up in the middle of the night. Keep kids calm. The more anxious and fussy and grumpy they get, the worse their stridor will get. Cold air is actually really beneficial. So in the winter, you can take the kids outside in the cold air and they breathe the cold air. It pulls down that inflammation in their upper airway. In the summer, you can stick them in front of a freezer. So cold air can be beneficial for acute exacerbations. Obviously, oxygen if they're hypoxic. Does not respond to albuterol. Again, this is an upper airway issue. Albuterol works in our lower airways. But we can treat them, right? We usually give them racemic epi or just regular inhaled epi, right? So 0.5 mLs of 2.25% racemic epi. Racemic epi is in the respiratory distress protocol for croup. If you don't carry racemic epi, you can give them just regular epi. It's 3 to 5 mLs of 1 to 1,000 mixed into it. Just throw it into a neb and let them breathe on it. It actually works really well. And there's actually a couple studies showing that it may actually in some ways be superior to racemic epi. But they do tend to get more tachycardic with regular epi. And there's some other issues with it. But it works really well. So if you don't carry racemic, you can just throw that in there. All right, last one, case number 4, 1-year-old female with difficulty breathing. Arrive on scene to find the patient unresponsive with stiff extremities, irregular breathing with intermittent snoring. So what's wrong with this kid? Yeah, seizure, right? So the number of times when I was a medic and got a call for difficulty breathing that was a seizing kid was beyond count. And it still happens to me constantly in the ER. The families bring these kids in for difficulty breathing. Yes, they can't breathe because they're seizing. So you really get two problems with seizures, right? So one is that they intermittently occlude their airway, right? Kids have big heads, small, narrow anterior airways, big floppy tongues, right? And so all that means that at baseline, they're sort of prone to airway occlusion. And so when they're seizing, you get airway occlusion. The other is disordered breathing, right? Because they start to lose control of their respiratory drive at a point. And so not only do you get airway issues, but you also get some what we call disordered regulation of breathing or irregular breathing, okay? So you sort of get two respiratory A and B issues when you talk about seizures. This is that kid's vitals. She's unresponsive, extremities are stiff, eyes are deviated to the left, right? I couldn't make this any more obvious of a seizure, so I tried. So let's talk about seizures real quick. Child seizures are common. Fever, febrile seizures are the most common cause of pediatric seizures, but there's a ton of other things that can cause you to have a seizure in a kid. And in fact, seizures account to 5 to 10% of EMS or of ER presentations for kid. Is the most common neurologic disorder that prompts a visit to an ER in a kid. And a large percentage of kids will actually have a one-time seizure in their life, whether it's febrile or unprovoked, and then never seize again. There's something about a developing immature brain that tends to make it do some funny stuff. But there's all kinds of things that can also induce one. Again, 1% of ER visits, 5 to 10% of kids will have one in their life. Status epilepticus, seizures that aren't ending, occur in about 18 to 23 per 100,000 children. Historically, that was defined as greater than 30 minutes of a seizure or a series of seizures without return to baseline. If you read like textbooks, like neurology, old neurology textbooks, that was what it'll tell you. The reality is any seizure that lasts more than 5 minutes really has a pretty low likelihood of self-terminating. And once you get past 10 minutes, the chance of it self-terminating is pretty much approaches zero. So it's really a lot less than what it was historically defined as. I think the other part of that is pretty key too. Series of recurrent seizures without return to baseline, right? So if you stop, but you stay completely out of it, and then you start again 2 minutes later, that's all one seizure. You really are in status, okay? It's not sort of stopping and starting and stopping and starting. It really is a continuation of the same thing. Treatment. Airway support is key, right? So we talked about kids are really prone to airway occlusion. So airway support, it really is a big thing for these kids. And nasopharyngeal airways are great for these kids. They really are like God's gift to seizing children. So I used to never really use NPAs a lot until I started doing peds more, because I sort of thought they were worthless. Like, you're fine. You're either not occluding your airway or I'm just going to intubate you. But the truth is, again, what are kids and babies' primary airway? Their nose. They like to breathe through their nose. And the issue is that their airway is occluded. So if you can slide in something that quickly opens up that airway, that you can just rip out once the kid starts waking up, because they're going to eventually, they're not going to take an oral, right? Then this does great, right? And a lot of times these kids are so clenched, you couldn't get an oral or anything in them anyway, but that nose is always free and open, right? So nasal airways do great for these kids. Provide oxygen to maintain their saturations, and then assist their ventilations as necessary. Again, a lot of times, not just are you dealing with an airway occlusion, you're also dealing with some disorder breathing. So if they're only breathing 10 times a minute irregularly like our kid was, they're going to need some help with that breathing, right? And you'll be absolutely amazed. These kids who are satting like 80 and you're like, everybody's freaking out, throw a nasal airway in them, give them a couple bag breaths, slap them on a non-rebreather. You will be shocked and amazed how much better they look. Okay, they're still going to be seizing, but their sats are going to go up, their respiratory drive, everything is going to look better. And you bought yourself some time to sit there and figure out your benzo dose, to draw it up, and to get meds in the kid, to look for a line, to do whatever it is you need to do, okay? Because the key, seizures generally are well tolerated, as long as you don't have a respiratory arrest or become hypoxic and then start to code, right? So if you can fix A and B, then you bought yourself a lot of time to do other stuff. Okay, so that's the key. Support A and B, and then you can get to the other stuff. And then what else should we check in kids? Anytime you have a seizing kid, you should probably check their glucose. Even if it's a febrile seizure, you can't go wrong checking the glucose. Kids have low blood sugar stores. This kid who's been sick for a few days, you never know what you're going to find. Okay. So let's talk about what we're going to give the kid. First line drug of choice in control of status epilepticus is benzos. They rapidly cross the blood-brain barrier and potentiate GABA, and potentially is dependent on affinity, but whatever. There's 3 drugs we really think about: lorazepam, Ativan, midazolam, Versed, and diazepam, which is Valium. Traditionally, Valium was always sort of the gold standard, and we carried it for years and years in EMS because it was really the only one that you could give any route other than IV, right? And so we carried it for years and years. The problem is diazepam is really a crappy drug. It doesn't work that great. It's a dirty drug. It causes a lot of oversedation, a lot of side effects, and it's not the best drug. In reality, the kind of gold standards now are Ativan and Versed, okay? And Versed presents a lot of advantages, okay? Ativan works great given IV. It does not work great really given by any other route, okay? It's not very well absorbed IM, and you can't give it any other way. Midazolam, or Versed, is really the drug that has come to be kind of on the forefront now. And that's because it can be given a lot of different ways. It works very well when given IM, and it works great when you can give it intranasally. So especially when we're talking about my population of little pediatrics, right, that are A, pretty hard to get an IV in at baseline, right, and B, really hard to get an IV in when they've been sick for a couple days and now they have a fever and now they have a febrile seizure, and you're trying to get a 24 gauge into this little seizing, dehydrated child. Having something that you can give different routes, IM or intranasally, is a big deal. So looking at intranasal midazolam, it's long been used. We've used intranasal Versed for years in the pediatric emergency medicine world as an anxiolytic for procedures. It turns out it also works really, really well when you use it as an anti-seizure drug. So there was one study that it was actually done in India, looked at intranasal Versed compared to IV Valium, and the mean interval between control of seizures and drug administration was slightly shorter for Valium by a whole, 0.1 minute, but your overall time to seizure control was significantly less. Okay, so 6.6 minutes compared to 17 minutes. Why? Because we're not having to search for an IV, right? So a lot easier and quicker to give somebody, squirt something up somebody's nose than is to search for a little 24 gauge IV. And was equally efficacious, with no statistical significant difference in side effects. Another study was done that looked at Versed with IV Valium again, pretty much found the same thing. Slightly longer time from drug administration to seizure control, but way shorter time from contact of care to seizure control. What about compared to rectal? Because everybody used to talk about rectal Valium all the time. Works better. Higher rate of seizure control with intranasal Versed compared to rectal Valium. And it's actually even better studied outside the hospital. So there's been several studies comparing intranasal Versed and rectal Valium for families, like sending them home with a prepackaged Versed syringe that they can squirt up the kid's nose instead of the rectal diastat kits. In every single study, it's been shown to be superior. There was a big EMS study that was done on 857 seizure patients out in Utah. 39 with intranasal midazolam, 18 with rectal diazepam. Intranasal Versed was shown to be vastly superior. That was like the first big original one. There's been 3 or 4 since then, even bigger. All of them have been shown to be successful. So intranasal Versed is by far, for kids, a preferred route, okay? If you have atomizers, they're like super cheap to buy. They're literally like 5 cents each one. You can buy like boxes of those things for not that much. You can atomize it up their nose. If you don't atomize it, actually the first study, the one that was done in India, they didn't use atomizers. They just dripped the Versed into the kid's nose. Still works. You just got to be a little slower and more deliberate about it. But intranasal Versed, you can use intramuscular Versed. It does work very well. Takes a lot longer though. So intranasal Versed is definitely sort of our preferred route for kids. Remember, we sort of simplified the dosing. All the benzos for kids are 0.1 milligrams per kilogram up to the adult dose. So please don't give, 15 milligrams of Ativan to the kid because that was the weight-based dose. There is a max there. And then for intranasal Versed, it's 0.2 milligrams per kilogram. I think the protocol says up to 5 milligrams right now. We're going to change that to 10 though, eventually when I get we update them. Because you can definitely go higher in that. And so 10 milligrams of intranasal Versed, kid's fine. I give them 10 all the time. But anywho, 0.2 milligrams per kilogram for intranasal. All right, guys, and that covers respiratory emergencies.
So we got a couple of good questions that came in, Doc.
Okay.
So several people actually have texted and said, hey, the dose for nebulized epinephrine was on the slide was confusing. It said 3 to 5 milliliters of 1 to 1,000, which would actually equal 3 to 5 milligrams instead of 0.3.
Oh, I probably left out a 0 on it.
So,
I made it like last.
the question is, we use 1 to 1,000 or 1 to 10,000?
1 to 10.
Okay, yep. So 1 to 10,000 if you're going to nebulized epi, answers that for everybody asking that question. The other question, interesting, they asked for febrile seizures. How important is it for us to try to cool the kid?
It's not. It's a total misnomer. So it's really not important at all. Don't worry about it. Treat the seizure. I'll worry about the fever when they get to the ER. So the fever creates the seizure in the sense that in the brain, there are chemical changes that take place when your body resets its temperature set point. And that is what triggers the seizure in these babies with immature brains. Once the seizure has started, treating the fever does not stop the seizure. You got to treat the seizure like a seizure. And so it's more important to give them seizure meds like benzos than it is to worry about that fever. The fever is not the issue. And it's not that, it's not caused by the height of the fever. So, it's not that their fever got so high that their brain is like cooking or proteins are breaking down or neurons are being destroyed. It really is just related to the chemical changes that take place in the immature brain. So one of the genetically familial febrile seizure disorders that are genetically mediated, your brain works off the flow of ions across membranes, cells do. It turns out there's a leaky sodium channel that's associated with that genetic malformation. And so when these kids get fevers, that sodium channel busts open and that inflow of sodium is what creates the seizure. So we know these are really just related, not necessarily to height of fever or rate of rise of fever. It really is just the presence of fever that sort of creates the seizure, but then you have to treat the seizure. Treating the fever doesn't necessarily help that. So don't worry about it. Yeah.
And so, go ahead.
I know you just touched on it, but I've been pondering it for 2 weeks. It was like a 7-year-old in status, and then they had already given rectal Valium with no relief. And we called y'all to give IV Versed, and they ordered 8 milligrams. We only carry 4. The max dose for Versed in adults is 2. So I was wondering.
8 IV?
8 IV.
I have a feeling I know exactly which attendee did this because they actually told me about this 2 nights ago. Don't do that. Give the max a little bit.
Okay, so I've been talking for a week and I couldn't figure out why the max dose or why they would order so much IV.
We'll talk about that when I'm not on mic.
I'm sorry.
You're good. We'll talk about that.
Yeah, so actually he asked a question that we've had from other people, which is, how much Versed do you think we should be carrying? Because at Centerport, we carry 2 milligram doses in every box. And that, I don't know what the other services do, but I have the feeling it's probably similar.
Yeah.
Do you think we should be carrying more than that?
I mean, personally, yes. And I say that sort of selfishly in the sense that for my kids who are going to be getting intranasal, 5 to 10 milligrams is not an unreasonable dose for some of those kids, especially depending on their size. And it can take a couple of doses. Even, even some of these smaller kids that are truly in status take 2 or 3 rounds of benzos, even IV to treat. So if you're giving them 2 milligrams, you know, it's not uncommon to get up to 6 milligrams to get seizure control. So kind of selfishly, I would say yes, but I also understand the amount of times we're giving benzos versus buying drugs that are expiring and the logistics and economics of that. So medically and selfishly, I would say yes, but the agency administrator hat that I sometimes wear would say maybe, maybe not.
Very good. Does anybody else have any other questions?
What about using an atomizing saline flush, instead of just putting a couple of drops?
Yeah, absolutely. It works great. I've done that before.
So I felt like it would.
Yeah.
Maybe thin it. A little
Yeah,
bit.
100%. If you've got them and you want to use, if you're suctioning out some bronchiolitic, sticking the atomizer on the little saline, on a saline flush and just squirting a bunch in there, it definitely works well.
Okay, everybody, if you're listening online, the link for the attendance form is in the chat box. We're going to take the password for today's class is respiration, by the way. We're going to take just a few minute break, and then we're going to come back with Dr. Evans. So please stay tuned. Everybody, welcome back. We're fixing to get started with Dr. Evans. Remember, if you're listening online, you can click the link to the attendance form. If for whatever reason you can't access that, if you're watching on your phone, for example, you can send an email to Alabama EMS Challenge@gmail.com. Doesn't matter what the subject is, you'll get an automated return email with a link to the attendance form. One attendance form per participant, please. Please fill it out even if you don't think you need the Con Ed, so that we can keep track of who's participating and get your feedback. Please be serious about the feedback. We do review it on a regular basis and change our programming based on the feedback you've given us. So we want to make this as best as we can for everybody, and we appreciate you being here. Dr. Evans.
All right, guys, we're going to get into some respiratory emergency stuff. Before we do, Dr. Ferguson is currently at a conference, and he texted me this morning, wanted me to go over and make sure that all the crews that are transporting in the Birmingham region, really anybody in the state, still, most hospitals are requiring that you still wear a mask. I think he's had a couple complaints, a couple places. So if you're transporting patients to the hospital, still make sure you throw your mask on. And more importantly, if you have a sick patient that you're transporting, make sure you take them in on a monitor. I know at least at UAB, the wall times are getting pretty insane. We're sorry about that. We're working on it best we can from our side. But with the increased wall times, not only at UAB, but other places, just make sure that you have them on a monitor, because you may be potentially sitting on a wall for an hour or two. Again, we're trying really hard to make that stop, but it kind of is what it is. All right, so respiratory emergencies. So we're talking about respiratory emergencies these days. It's the vid. It's always COVID. Everybody's COVID. Not really. So I found this and I loved it. Chuck Norris has been exposed to coronavirus. Now the virus is in quarantine for the next 2 weeks. So really, really briefly, just to kind of help understand the treatment that we're going to do for some of these respiratory emergencies. It is important at least to know a very basic overview of the respiratory system. So we'll fly through this. This is not an anatomy class. I know y'all know most of this already. But our respiratory system in general is designed to take our oxygen from the outside of the body, bring it in, exchange it for carbon dioxide, and get the carbon dioxide back out. When we talk about terms, so terminology, ventilation is the air going in and out. That's the actual act of breathing air in and out. Respiration is a cellular level. Now, I know we use them interchangeably, and I'm going to use them interchangeably, admittedly, in this lecture, just because that's what we say in medicine. But when we talk about true respiration, it's the gas exchange of O2, CO2 within the alveoli. All right, so you have your upper airway, your lower airway. Upper airway, all these structures, it basically goes distal to the epiglottis into the upper trachea. The upper airway is responsible for warming, humidifying, filtering the air as it goes through the nose. Obviously, it goes through your mouth. You don't get that. And then remember, the airway is anterior to the esophagus. It matters mostly if you're critical care medicine, where you're going to do a cryoc and some of those kind of things. Bronchi, you have two main bronchi. They go into secondary, blah, blah, blah. I'm saying blah, blah, blah it's important. We're just going through very brief anatomy. Remember, you've got 2 lobes on the right, you've got 3 lobes on the left. Now, here's where the rubber meets the road as far as respiratory emergencies go. Very few of them, although there are some that involve the upper airways. Most of the pathology is going to involve the alveoli. This is a network of capillaries surrounding these alveoli. That's where your gas exchange comes into play. The difference, the gas exchange problem is what's going to cause you symptoms with a lot of these things that we're going to talk about, like COPD, emphysema, even pneumonia, some of those kind of things. And the gas exchange is via diffusion. So if you kind of remember from science class, if I've got a bunch of particles on this side of a membrane and not so many of the same particles over here, well, naturally, these want to go over here to equalize the pressure. It's the same way here. So you've got tons of oxygen flooded in this alveoli. As the blood passes, that is deoxygenated blood coming from the pulmonary venules, the pulmonary arterioles, they're going to get oxygenated via diffusion. And so the oxygen is going to flow in, and the carbon dioxide that came from the cells is going to go here and then back through the same process. I'm touching this and I'm not meaning to, through the pulmonary venule and get out. Okay. Real brief, and I apologize. Respiratory centers, this is also kind of important when you talk about the speed and the depth of breathing. So we have chemoreceptors in our brain, in our carotids, our upper aorta, as well as you have stretch receptors in the diaphragm. And all those kind of work together to say, hey, how fast do I need to breathe? How deep do I need to breathe? The majority of breathing is run by actually your CO2 level. It's not run by how much oxygen you got in your body if you're a normal person. Now, we'll talk about the differences when you have an abnormal respiratory physiology. But normally, your body says, up here in the medulla, I've got an increased CO2 level. When you have increased CO2, that gets converted to acid. So your mind or your brain registers there's too much acid going by. So speed up your breathing, breathe off that acid, which is why when you have DKA, diabetic ketoacidosis, that's why you get Kussmaul breathing. It's trying to breathe off, your body's doing everything it can to lower the acidity in your blood. So that's the purpose. So increase CO2, increase acid, breathe faster, breathe deeper. You do have a very minor effect on a normal person from a decreased oxygen level. There are receptors there. So if you are just truly hypoxic, there are some receptors throughout your body that registers that and tells you how to breathe. So in general, if your pH is too high, so that's alkaline, not enough CO2, it tells you to decrease your ventilation, so we need to build that back up. If your pH is too low, that's acidic, bring it up. So increase your ventilations, okay? All right, so now let's get into mostly the assessment part. So it's gonna be almost the same for everybody. This is where you kind of, as EMS providers, we get to be almost an investigator, so to speak. It really starts the second you hit the door, just like most every assessment you do with the patient. So you walk in the room, you just see what's your general impression of the patient, how do they look? And this kind of goes back to the way Ferg does his EKGs. Too fast, too slow, okay. You walk in the room, is this patient super sick? Or is this patient got a little bit of time? I can tell they don't feel well, but do I need to do something to them right away? That's your general impression, that's you walking in the door. Are they in a tripod position? Are they cyanotic? So tripod and cyanotic, I've got to do something to them right away, and I don't need to delay for this further detailed assessment, okay? How's their mental status? Are they agitated, anxious, altered? Are they lethargic? If it's a respiratory call and you walk in and they're lethargic, that's kind of worrisome. Maybe they took too much medicines, but also they may be going into respiratory failure. And then the next is, can they talk to you? So you walk in, you've already looked at all this, you walk up, hey, Dr. Duerring, my name is Dr. Evans. Can you tell me what's going on? If they're talking like that, that's worrisome. They don't have enough breath within them. They don't have enough respiratory effort and drive to be able to speak in full sentences. That's concerning. You need to intervene on that pretty quickly as well. And then when you go to effort, can they talk in complete sentences, but then do they have the pursed lip breathing, where you have the COPDers that are, those are some things you need to look for. Are they severely distressed or labored breathing? All right. So we've already done our kind of just cursory review, just talking to them, doing a lot of information without ever touching them, before really ever getting close to them. Well, now we're getting to them, we're actually doing our assessment. So we look at their airway. If they can talk to me, they have a patent airway. If you don't hear severe stridor, they have a patent airway. So we can move on to the next. Are they breathing? This is one of those times, if it's a respiratory call, please don't write on your chart, other 18 breaths a minute. We have a problem with some of our nurses doing that. You can see if you walk by a room and you tell they're breathing about 40 a minute, you look in the chart, oh, 16. It's funny how everybody in the ER is 16 to 18 breaths a minute. That's not true. So if it's a respiratory call, actually count the breaths. It will really give you a lot of information. Circulation, put your hand on their skin. Do they have warm, pink, importantly? Pink means they have some oxygen going around. Dry skin, not diaphoretic where you're worried about a cardio issue. And then do they have strong peripheral pulses? And then disability, just basically how's their mental status, okay? And I put on there 12 to 20 is normal for adults. It can get much higher for kids, just keep that in the back of your mind. Babies especially, they can get up to 40, 50, sometimes 60 and still be okay. 60 is a lot, so I usually stay in that 40 range, 40 or less for babies. And Dr. Duerring can shut me up or correct me at any point in time if he wants to. But okay, so we've looked at them. We know we've got some time. I don't have to intervene on them right away. We've done some cursory vital signs, just the basics to see everything at every step of the way. If you find a significant problem, stop and fix it, especially with respiratory. If there's a big issue with respiratory and you find it, stop and fix it, okay? Whether that's airway or they're in significant distress that I've got to intervene on. So now we get into a focus history. We're going to assume this patient doesn't look well, but is well enough that they can participate in a focus history, because this is where they will give you the diagnosis 90% of the time. It doesn't even matter if you do a physical exam, please. But your focus history, we teach our residents, that's where you get the vast majority of your diagnoses. They will tell you what's wrong with them. So to do that, you do your sample or your OPQRST. And just to remind folks, sample is signs and symptoms, allergies, medicines, pertinent history, last oral intake, events leading up to the call. OPQRST is onset, provocation, quality, severity and timing, or I use sample. I'm a sample guy. But anyway, however you do it. Basically, you want to know, when did it start? Is this something they've been dealing with for a week and they just kind of got tired of dealing with it? Or is it abrupt onset 20 minutes ago? Because that leads you down two different paths, right? That's a chronic process that's getting a little bit worse versus something really bad, really acute, that they went from normal walkie-talkie and now all of a sudden they can't breathe. So timing, onset of symptoms, whether it's gradual or abrupt, does it change with positioning? All right. So if they can't lie flat, what do you think they may have? Edema? Yeah, exactly. For whatever cause, they have fluid probably in their lungs, because that's the one thing that would layer. If it's just a constriction, that doesn't matter quite as much. So yeah, if they say, I have to sit up, I can't lay flat, or I normally sleep on one pillow, now I'm sleeping on 5. Okay, well maybe this is an edema issue, because the treatment becomes very different that we'll talk about later. Are they having a cough? Is it productive or dry? Productive kind of leads you down. All right, maybe there's some edema, maybe it's pneumonia. If it's very dry, that's another bronchoconstrictive pathway usually, or it's COVID. It could still be COVID. And color of sputum, that's not as important. If they tell you, cool, let me know. Additional symptoms that are really helpful, are they having chest pain? Have they had fever to indicate there's an infectious process? Are they wheezing? Do they normally wheeze? Have they smoked for the last 70 years? Do they work in a cotton mill and they've had all of a sudden cotton dust exposure? Or a guy had this week, actually yesterday as a matter of fact, he works around chlorine gas. They had a gas leak. He said, I have no lung problems at all. Well, yeah, I smoke a lot for the last 30 years, but I was fine. We had a chlorine gas. Now I just really cannot breathe. Well, that's an irritant exposure. Okay. And then have they had trauma? Then you worry about the bad stuff like pneumothoraces. All right. Medications can also be really good clues. Are they currently on antibiotics? Well, then you think infectious process. Do they normally use oxygen? This is incredibly important for somebody that might decompensate en route when you get to the hospital. Yeah, hey doc, they normally wear 2 to 4 liters every night. And I got them on 6. Well, I had to put them on a non-rebreather. Well, that tells me that their chronic process is kind of tipped over the edge and they've fallen off a cliff. I got to worry about that kind of person that has really drastic increase in their oxygen level demand. Are they normally on steroids? That indicates that's probably an inflammatory process like emphysema or asthma. Do they use inhalers? Emphysema, asthma. Are they on cardiac drugs? Do they take nitro, flecainide, all the cardiac drugs that you know? Well, that may push you down a different path. So it's a lot of words that basically say there are clues that you can use before you ever get to the patient laying hands on, just talking to them. You find out a lot of this stuff, you'll already know that's a COPD exacerbation. You might be having a heart attack or you got an infection. And that'll be helpful when it comes to treatment. So when you assess, I know we don't listen as much now in the world of COVID. We definitely don't feel as much or lay hands on patients in the world of COVID. Now that we're kind of getting a little bit more vaccinated, you can still do a lot of this from the posterior of a patient where you're not getting them breathing right in your face. I listen on the back. I don't like listening on the front. Obviously, if on the stretcher, it's kind of hard. Some of these people can't sit up as well. But if you can, listen from the back. It protects you and it gives you better breath sounds. And then even lay your hands on them. Purpose of that, you look at their skin color. Are they cyanotic? You feel them. Is their skin warm? That's why I actually will lay my hands on their ribs and feel the movement. Is it symmetrical? If it's asymmetrical, we might have a pneumothorax. But as I'm doing that, I'm getting a lot of information from that. I'm feeling how deep it is. I'm feeling the respiratory rate. Because my ears don't work after a decade of being on a truck and being in a cotton mill, which is why I brought up cotton mill earlier. And then look at their effort. You're also going to get a lot of information. So these are good patients to take their shirt off. Obviously, if it's a female, you can leave their bra on. Please do keep them covered and as modest as you can. But by taking shirts off and exposing their skin, you can see skin color, you can feel skin temperature, but you can also look for things like retractions. Are they pulling so hard and working so hard to breathe that they're pulling the skin in between the ribs? Or you have subcostal retractions, clavicular retractions where they're pulling down here on the top. Those are always helpful. It's one of those you can't see it or treat it, or you can't treat it unless you can see it, just like a trauma. And then any adventitious breath sounds are abnormal. Wheezing, rhonchi, which is that noisy breathing, rales, which is the wet, bubbly breathing, and obviously stridor is real bad. But if any abnormal breath sounds are abnormal, that's just the best way to say that. So signs of stress. If you see this guy, you know, obviously he's in the hospital. But if you walk up to him, he's sitting on a chair, he's just struggling. He's got this body habitus, which tells me he is not a healthy man at baseline. You know, I've got to do something to him. This guy's in severe distress. Just looking at the picture. We don't even have to hear him, talk to him, anything like that. So signs of distress where I need to do something is, do they have severe tachypnea, too fast, or severely slow breathing? They're only breathing 2 times a year. I got to fix that. Cyanosis, it's a late and kind of unreliable sign. There are a lot of other signs prior to that, such as mental status. Do they have nasal flaring where their nares are starting to get a lot larger? That's more noticeable in kids. Obviously, I've got a bunch of hair. You're not going to see my nasal flaring quite as quickly, but that's a good sign in kids. If you see nasal flaring in a child, that's a good indicator that you need to do kind of work with their breathing. Retractions that we talked about, or abdominal breathing. It's not normal for us to sit here and suck wind with our belly, okay? Oxygenate immediately, especially if you see decreased loss of consciousness with a pulmonary complaint. You get a phone call, hey, mama said she can't breathe, and you get there and she's profoundly lethargic. Well, if that was a call out, I'm probably going to slap oxygen on her while we're figuring it out, okay? We're going to talk more about, I don't want you to over-oxygenate folks unless one of these things are met, okay? Again, you can always pull oxygen off, but if you're behind the 8 ball and you didn't put it on quickly enough, that could be an issue. If there's possible shock for whatever reason, you're going to flood the system and try to get whatever few hemoglobin molecules they have saturated. Same thing with severe hemorrhage, just whatever blood they got in the system, you're trying to get as much oxygen you can in it. And then any signs of respiratory distress from up here, I would go ahead and put them on some supplemental. It doesn't have to be 15 liters, it's just something to get them started. All right, golden rules in respiratory emergencies. This is where the mental status comes into play. Usually, hypoxia presents as they're very restless, anxious, even combative sometimes. They're fighting to get oxygen in their body, if you kind of think of it like that. So if you see that and you don't have another reason like they're gorked out on methamphetamines, assume it's hypoxia. Now you can find out pretty quickly, but at least have a high index of suspicion that that combative patient may have a metabolic issue, but also could be hypoxic, okay? You got a bunch of causes of hypoxia. It's not just, I don't have enough oxygen in my body. That's one of them. There's not enough oxygen getting down into my lungs, diffusing through and perfusing to the body. But you can also have certain things like anemic hypoxia. I don't have enough blood to carry the oxygen around. That's why the grandmother who's having a GI bleed is short of breath. She's not short of breath because she can't physically breathe or respirate. She just doesn't have enough hemoglobin to carry the oxygen around to the body. You've got stagnant hypoxia. This is a shock. Basically, you have too low of a blood pressure to perfuse the rest of the tissues. And then you've got histotoxic hypoxia, things like poisoning. So cyanide, it shifts that. Do y'all remember the oxygen dissociation curve? Y'all remember pretty well. Y'all firefighters, y'all know it more than probably the doctors do because it works. Y'all use it more than we do. But a lot of the poisonings, especially cyanide, will shift that. Carbon monoxide poison is another one, which y'all are way more familiar with than any of us. And then the next one is, so you've got, I'm fighting to get oxygen in my body. The next one is, I've got too much CO2 in my body. Those guys are very altered, but they're more lethargic. They're more somnolent, which there's a difference in somnolence and lethargy. That's just one of the things. Somnolence is sleepy. Lethargy is, I'm barely rousable. So if you come to the ER, it's always good. If they're just kind of sleepy, but real easy to wake up, they'll talk to you, that's somnolent. If they're gorked to the point where you're like, I really am having a hard time waking them up, that's definitely lethargic. But that usually comes from too much CO2 in the body. You're too acidotic. Okay? So now we're going to get into the pathologies. So upper airway obstruction, common in kids. It's mostly due in adults to food, rarely due to objects, but it can still be due to objects for sure. In kids, it can be due to food, but it is very common, have to do with an object. So if you go to and Dr. Duerring has probably talked on this a whole lot, but if you go to a scene and they say, I don't know what happened, but my 2-year-old was playing in the other room and all of a sudden they started complaining of shortness of breath. They started breathing real heavily. That patient has an obstruction until proven otherwise. Okay, because kids don't have COPD, they don't have heart failure usually. They have probably put something in their mouth and they've probably aspirated it. Okay, we're going to move on from that. Just the next one is tongue angioedema. Is there something actually blocking the airway that's physiological? And then is there swelling of the upper airway? So things like Ludwig's angina. They've got a dental infection that now has spread to the anterior neck tissues, and you've got a tongue that pokes out. This neck that normally is, mine's not real skinny, so I don't want to say skinny on my neck, but is now huge, like a 500-pound person. That's concerning for a deep space neck infection that will occlude their airway. And then epiglottitis. Remember, the epiglottis is the flap that sits over the esophagus. If that gets too swollen, it can block the airway, everything in the upper airway. So the underlying problem here is there's a block. And if there's a block, I can't get oxygen in and out. Oxygen in and CO2 out. So it's a ventilation problem. Your assessment, you're going to kind of say, can they speak to you? If they can speak to you, even if it's kind of a muffled voice, there's something probably there, but I don't have to intervene right this second. I'm just going to keep a really close eye on them, keep them as calm as I can. Are they moving air in and out? So is this the patient that is saying, hey, I'm choking? Well, if you can tell me you're choking, there's something there, I get it. But we got time to at least get you to the hospital. I don't have to intubate you right away or grab something. If they're complaining of dyspnea, again, that's a good sign. But if this is the patient that's like this, that's grabbing their neck, you hear no sounds, you see no air movement, and they're struggling to try to get some breath in, this is the one you want to really intervene on fairly quickly. And then obviously this one, I'm going to do the Heimlich maneuver. Remember, it's fist here, you do upward thrusts. If they pass out, you're putting them on the ground, and you're going to do the same upward thrust, but by standing or kneeling over them. So push in and up toward the head, okay? If they lose a pulse, or if they completely stop breathing and go unresponsive, then you have to worry about bagging them and try to actually physically get the obstruction out, okay? If you can see the obstruction, grab it. No more blind finger sweeps. We hadn't done those for years, but a long time ago it was, if you can sweep and try to feel it, go get it. Now they're for years they've been recommending against that just because you could push it down further, okay? If you are a paramedic, so we've talked about Heimlich, if you are a paramedic, or even an advanced to a point, you can get a little deeper into the view. So a paramedic, you're going to get in with your laryngoscope and see, okay, I'm bagging them, but nothing is going through. Take your laryngoscope, and if you see this, you've got McGill forceps on the truck, gently try to grab this and relieve the obstruction by pulling it out. Let's say it's that 2-year-old. You see a ball sitting there, and I wish I'd have found a better picture, but you just see something occluding this airway. They were playing with marbles. Marbles really hard to get with McGill forceps. I don't know if you've ever used the McGills, but they're hard to pick up with. Really, anything's hard to pick up with McGills, but even round, smooth objects. What's something you can do there? Yeah, exactly. So if you didn't hear him, he said push it further down. I've got to relieve the obstruction. We'll manage it in the hospital. They'll get a bronchoscopy. We'll get it out that way. If you cannot relieve the obstruction, we don't have cricothyrotomies yet in Alabama. So you got to do something. And exactly what you're talking about. You basically take your ET tube and you jam it down. And you try to main stem the ET tube by pushing whatever side. It's usually going to go to the right. But you're trying to push the obstruction down to at least have one lung to ventilate with. One lung's better than no lung. Okay, so that's your last ditch effort, but definitely. All right. So if you have an upper airway obstruction from an allergic reaction, obviously do use your drugs. Benadryl, epinephrine, albuterol. Epinephrine is going to be your go-to if you're having any kind of upper airway symptoms. You see tongue swelling, you see posterior pharyngeal swelling. I'd go ahead and go straight to epinephrine. Okay. These other things will take a little bit of time. Epiglottitis is racemic epinephrine. I think Dr. Duerring talked about a little bit how to mix that up, but just to reiterate, it's in your protocol. You can use the 1 to 10,000, 1 to 1,000. The protocol talks about taking 0.3 of 1 to 1,000, mix it in 3 milliliters of normal saline and put it in a nebulizer and go after it. But there's a lot of different ways to skin a cat. Croup is humidified oxygen. It's real hard to get humidified oxygen on the truck, but some places have it. We never had it. Sleep apnea, it's just on here. It's CPAP. We're not going to do anything with that. Okay, we're going to move on to COPD. So, okay, calm down. That's not whistling. They're just wheezing. All right. So COPD is a broad category. It encompasses emphysema, chronic bronchitis. Even asthma still kind of fits in that because it is a chronic obstructive process. So that's why I included it in there. Emphysema. Emphysema is destruction of the alveolar walls. So normally you have a bunch of tiny grapes all in a cluster, and those tiny grapes are a certain size for a reason. It allows for maximum oxygenation, maximum concentration of oxygen in an area to diffuse across the cells. Well, if you think about it, can I borrow your cup for like half a second? No, all right. Oh, that's Shay's coffee. Well, imagine I have this as one of my alveoli. It's full of oxygen. Well, now the concentration of oxygen is so high that I can actually diffuse real well. Remember that gradient we talked about earlier? Well, in emphysema, you've got a lot of irritants that have destroyed the alveolar walls over time. So now these small grapes that are maximized now coalesce and become one very large alveoli. Okay, so I went from that cup where I can have a very large concentration of oxygen to, let's say, just for comparison purposes, this room. If I take that same amount of oxygen that was in that cup and just disperse it in this room, the concentration in the whole is a little bit less, right? So the diffusion is going to be less. The gradient now is not as high. So that's where this becomes a problem. You don't get the diffusion of the oxygen and the CO2. So these patients will often have dyspnea exertion. They're going to have some history of exposure. They smoked for a long time. They worked in a mill or something that had long-standing irritation. But the looks of these patients is very different. They have that barrel chest. And what that comes from is, remember the diffusion part. I can't get oxygen diffused really well, but I also can't get the CO2 out very well. So it gets trapped in that alveoli, gets trapped in the lungs. So now the anterior posterior diameter of the chest starts to, just think about it's blowing up a balloon, right? So the chest will actually get larger, and that's where you get the barrel chest. These folks, they're going to use pursed lipped breathing to try to give themselves extra peep, to splint the airways open to try to get the extra air out. So that's a physiological thing that their brain says, hey, if you do this, you could actually help yourself when you get into a crisis. And then, of course, they're thin, emaciated. They're like the guy that we saw a little bit earlier. It's not going back that way, but that's a emphysema kind of guy. Very thin upper chest. I guarantee if you looked at his anterior posterior diameter, it's a large chest. Okay. They call him the pink puffer. So they've got that pursed puffing breathing. And they're usually pink because their skin is just the way they look. So management on these emphysema, you're going to notice this is going to be for every single person we talk about. So the management's kind of easy in respiratory. Make sure they have an airway. You're going to give them O2 if they need it. These are not any of the folks that you want to get 95, 100%. I'm perfectly fine if they're 92% when they roll in. That's very reasonable. These folks probably live at 89 to 93 on a daily basis. I don't need to get them normal, okay? As long as you get them above 92, whatever you have to do to get them above 92, that's fine, okay? IV access, because tachypnea can make you dehydrated. They can tire out. They can have other issues. So having IV access would be very beneficial because you don't want to get it in an emergent setting. Everybody that has shortness of breath, I don't care if they say, I have asthma, I've always had asthma, I get a 12 lead on them every time because you never know. It's just like I would say, not all that wheezes is asthma. There's a lot of other things that can cause wheezing, including airway obstruction. Not all that shortness of breath is pulmonary driven. It could be cardiac driven. Oh, sorry. Bronchodilators are going to be your drug of choice on this. Albuterol, those are your beta agonists. Those are your smooth muscle dilators in the bronchioles. Mag sulfate is a category B drug, but it's another, if you got somebody that I can't get them oxygenated, they're wheezing like crazy, but I can't get them better, mag sulfate is an adjunct you can use. And then if they're in severe distress, go on and just slap them on BiPAP. Okay. The one thing I would say, if you're going to put them on CPAP, not BiPAP. If you're going to put them on CPAP, at least listen to their lungs and make sure they don't have a pneumo. Because emphysema folks, they do have blebs. They do have large bubbles in their chest because of all the air trapping. So sometimes it's not an emphysema exacerbation. They've popped a bleb and they've got a pneumo. So before you put them on positive pressure ventilation, just definitely listen to their lungs, make sure it's bilateral and you're not suspecting a pneumo, because positive pressure in a pneumo will make the pneumo worse. And then down the line, steroids are beneficial in a lot of these respiratory cases. They don't work right away. They're 2 to 4 hours down the line of when they work, but getting them on board will help. It's not on Alabama EMS formulary yet. If you work over in Georgia, Tennessee, you can do it there. They carry Solu-Medrol in their bags. Maybe one day we'll get there. We'll talk to the assistant state medical director at some point. We'll see. But again, we don't have it because it doesn't work immediately. It takes time. So it's okay. Most of the Birmingham transports, you're perfectly fine. So when you talk about these emphysema or COPDers, you worry about knocking out their hypoxic drive. That's been an issue where you'll see docs, you come in and they're on a non-rebreather. Oh, don't do that. Pull that off of them. You're going to kill their hypoxic drive. No, you're not. You're not. Hypoxic drive is a phenomena that does happen in COPDers. And this is because their body is bathed with so much CO2 over time that basically their brain is just tired. It says, it's always so high, I'm not going to let that drive our respirations anymore, our ventilations anymore. So it becomes an oxygen-driven process. When they're hypoxic, it stimulates them to breathe. Well, in theory, and it does happen rarely, if you give them too much oxygen for too long, yes, it can impair their breathing. It can knock out their respiratory drive and actually cause them to breathe less or stop breathing. But that's a long process. in a 15 to 30 minute transport, a couple hours on the wall, you will not knock out their respiratory drive. If they need the oxygen from 15-liter non-rebreather, put them on 15 liters non-rebreather. If they need the CPAP, put them on the CPAP. And if somebody says otherwise, tell them talk to us. You will not knock out their hypoxic drive with a short-term high concentration. I'm not going to leave it on them long, because the longer they're on it, the higher the chance that you can knock it out. But we're talking most of the time, they're going to be on it for a number of hours, 24 hours, something like that. Okay. Chronic bronchitis is very similar to emphysema. It's just the physiological process is a little bit different. This one is a mucus production issue. It's a long-standing irritation. And so if you've got the bronchiole, well, now I've got a ton of mucus that just is constantly lining that bronchiole. And then over time, if there's another irritant or another agitating factor, they're going to constrict. Now they're constricting on an already small airway because of all the mucus. Whether they're sick and more mucus comes up, or they get around smoke, or they get around some irritant that constricts, that's going to cause their exacerbation. So this is a ventilation and inflammation issue. The inflammation is limiting your perfusion, but you have trouble getting the air in and out. The other one is I can't get the air exchanged, but getting air in's not so much of a problem. Getting air out is kind of a problem because everything's big and floppy. But this one is actually a ventilation problem. So a chronic bronchitis, you're going to see those long-term history of exposure to toxins. They have frequent respiratory infections because the mucus production, mucus sitting in there is a breeding ground for infections. Somebody's going to say, man, I always have pneumonia. I always have bronchitis. I always have these pulmonary issues. And they're going to cough up a bunch of sputum. These are the folks, if you think about, thin are usually pretty dry. Fat people, we're usually pretty sweaty and wet. So chronic bronchitis is your blue bloater, okay? They can't get the oxygen in. So remember the pink puffer, they can get oxygen in, they have a hard time getting the CO2 out. Chronic bronchitis, they have a hard time with ventilation, so they have a hard time getting the oxygen in. So these are the people that would probably benefit the most from CPAP. This and another fluid process. So I like CPAP on these if they're in severe distress, but the big thing is we got to get them opened up. So management, same thing. Ensure the airway's okay, correct severe hypoxia, goal set over 92%, IV monitor, and then bronchodilators if they're wheezing. Okay.
Hey Doc, what about the ipratropium for bronchitis?
Yeah, ipratropium does have a role. So you've got albuterol, which is a beta-2 agonist. Ipratropium is a smooth muscle relaxant. It works mostly on your diaphragm. It's really one of those drugs where one dose is really all you need. You know, in the hospital, you'll see some people give the Duoneb, which is a mix of albuterol and ipratropium. You'll give it 3 times. It's not necessary. You can give it. It's just there's a max effect. So giving 1 dose of ipratropium to these will help. It will decrease some of that inflammation as well. So this is just a picture talking about your blue bloater of chronic bronchitis versus your pink puffer of emphysema. The treatment is the same. The pathophysiology is a little bit different. So I jump real quick to CPAP if they're in distress on this one. Not quite as quick on this one. I want to make sure a couple things aren't happening like a pneumothorax or those kind of things because they'll have big blebs on this. They won't have big blebs on the blue bloaters as much. Okay. Asthma. So asthma, this is one we know all about. We see this, God, how many times a day do we see an asthma exacerbation? Especially this time of year. You've got a lot of pollen that sets people off. So it's a lower airway obstruction. You get bronchospasm, edema, you do get some mucus overproduction. It's usually worsened by irritants, so have you ever heard of the thing loud smells? I'm from the country. Loud smells, something that smells very strongly, a lot of perfumes can set some people's asthma off. Again, if you get around smoke, if you get around a bunch of dust particles, that can set folks off. Obviously, if they get any kind of infection, that's bad. But even hormonal changes and emotional distress, if you have a really terrible asthmatic and it's a female and it's their time of the month where they have those big hormone fluctuations, that alone can set them off. So emotional distress can actually set off, and hormonal changes can actually set off asthma exacerbations. So the underlying problem, again, the airway is constricted, so getting the air in and out is an issue. So these can be hypoxic. Your assessment, you're going to hear a non-productive cough, wheezing. They're going to speak in just a couple word sentences. They probably will use accessory muscles. Okay, so if you look right here, this is a normal airway. You see it's nice and patent. It's real hard to see, and I apologize for those on the screen. But when you have asthma, they have already inflamed and constricted, thickened airways that are prone to getting more constricted. You get any inflammation and mucus production in there, well, now you've just closed off an already stenosed tube, and it makes it hard to breathe. When we talk about status asthmaticus, that's a really, really scary one. So I don't get scared from a lot of these folks. A really sick asthmatic actually give me a little bit of pucker factor, because they get super sick really quickly. And if you have to go and do really heavy interventions like intubation, that's when these folks will die. Okay. And I put this off. Dan's son does a lot of these pictures. It's kind of, a lot of them are morbid. They do show what we go through a lot in EMS. However, this one is, I put this up here for a reason. The asthmatics that are super sick do actually scare me. Wheezing, dyspnea are the predominant symptoms, but if you hear an asthmatic that is silent, you have very quiet breath sounds that are extremely tight, those are the ones that should make you a little bit nervous, because those are the ones that's going to be really difficult to get them open. You're going to do everything you're trying. You're going to give them albuterol. You're going to probably go to your mag sulfate. But you see this kid right here, if you look at his face, he's got that sense of impending doom. He's retracting here above his clavicles. He's got some intercostal retractions. Just looks terrible. This would be a quiet breath. And so you're going to do everything you can. But as you're doing that, I'm probably going to have somebody up here at least getting intubation stuff together. Okay. The scary part about these is when you get this patient and they all of a sudden start to become somnolent, progress to lethargy, now I'm saying that they have respiratory failure, and I'm probably going to have to intubate them. The problem that we can intubate anybody, that's easy. Putting a tube down somebody's throat, we can do that. The problem is matching what their ventilatory needs are. That's really difficult. You have this person that's probably breathing 40 times a minute. You're trying to get them open. When you get them intubated, the upper airway is not the issue. Remember, it's the lower airway. Sometimes that positive pressure is all you need, but what if you get them intubated and you still can't get them open? That's when these folks will die, okay? So I'm not trying to belabor that point, but again, those are the ones that actually kind of scare me. So management. Albuterol is a mainstay. Give them albuterol as often as you need to get them opened up. If you notice that they're not opening up and you've got a decent transport time, mag sulfate's the next step. And it's not the 2 grams over 2 hours that you'll see. This is actually give it fairly quickly. It's 2 grams over 20 minutes. That's the respiratory dose of mag sulfate. But I'll even progress, and I have progressed on quite a number of occasions, that epinephrine is your next step. Again, it's a bronchoconstrictive pathway. Epinephrine is a beta agonist, so it's another tool in your box to help open up those lungs, okay? You're going to do the same dose that you would for an allergic reaction. It's 0.3 milligrams, 1 to 1,000 IM. Just kind of be careful, and it's actually category B if they're old or if they have a history of heart attacks, just because the epinephrine could precipitate that. One thing you can do to kind of help get you some time to try to avoid the intubation is CPAP and BiPAP at the hospital is what we'll use to help get the albuterol. So if they're really constricted, the albuterol is not actually getting down to the lower airways a lot of the times. So we'll splint them open with that extra positive pressure, and now the albuterol can get there, and hopefully that'll keep us from having to intubate. And most of the time, that's the key. All right. Pneumonia, we're just going to, everybody knows about pneumonia. We're going to kind of flow through this. The issue is you get a lot of fluid in the alveoli, so you lose your diffusion. These patients look ill. The main thing I want to mention on here is everything's the same, bronchodilation if wheezing. The biggest thing is if it's an infectious process, especially in the days of COVID, protect yourself. So wear your mask, preferably an N95. They wear a mask of some sort. And just, again, protect your crew. Wash the ambulance after you're done. All right, CHF and pulmonary edema. This is a volume overload process. You have heavy vascular resistance. The left ventricle is not working as well. So if the left side is not pumping forward flow, it backs up into the lungs. Okay. So NASCAR presents the CHF 500. And then the symptoms are shortness of breath, peripheral edema, chronic lack of energy just because they can't get the breath they need. They've got all this fluid, extra fluid they're carrying around. Difficulty sleeping. These are the people who sleep on 5 pillows or 3 pillows at night. Swollen or tender belly. So not all fluid sits in the legs. A lot of it will actually sit in the belly. And you can ask them, oh, you have CHF. Where do you normally swell when you swell? Oh, it's always in my belly. It's never my legs. So just because their legs are thin and not edematous doesn't mean it's not an exacerbation. Their cough, and this will be with a frothy sputum. That's because that fluid in the lungs. They pee a lot, usually because they're on Lasix. And then they can have some confusion, but that's a long distal process. So you can have left side of failure, right side of failure. Left side of failure is where you get your pulmonary edema, distended neck veins, and then as it gets really bad, it can flow over and affect the right side, so you'll get swollen feet and pitting edema. Right side, it usually is edema, not quite so much lungs, because if you think about the pumps messed up on this end, so if my right side pump's messed up, that messes up, backs up fluid in the body, not necessarily the lungs, until it affects so much fluid distally that it affects the left side of the heart. Now the left side pump's failing. Okay. This is tons and tons of fluid on the right lung. Y'all know a lot of this stuff. This is flash pulmonary edema. It can go with CHF. It can happen for other reasons as well. A bunch of irritation. The management of these. The mainstay of management, bronchodilators if they're wheezing, but I would lower preload and put them on CPAP. If they are super wet, you listen to their lungs, they're in distress, tons of fluid, I'm going to try to disperse as much fluid as I can. So I'm going to put that patient on CPAP probably pretty quickly. You can always pull them off. And we do that frequently in the ER. They look like they're sick, they go on BiPAP because I'm trying not to intubate them if I don't have to. It disperses the fluid. We've got time in the hospital now, give them Lasix. Their breathing's going to get better. They're going to be more compliant with their care. So, and then if you've got a prolonged time, now from center point you're not, but if you're listening, you do have a prolonged time, Lasix are in formulary in their category B. But again, that's going to be a process that doesn't fix them right away. The nitroglycerin will, because you're diminishing preload. So now that heart doesn't have to handle quite as much fluid. And the CPAP will, because it disperses some of that fluid. Pulmonary embolus, I know it's hard to tell, but right here, this all should be very white, and that's contrast going in the lungs. This is what's called a saddle pulmonary embolus, and there's a large PE right there. That's the one that'll kill somebody. You will drop dead, or you'll wake up dead with that one. This causes a ventilation perfusion mismatch. It affects the diffusion and the perfusion of the blood really to the lungs. Can cause sudden death. But it doesn't always have to be just a blood clot. You can have septic emboli if they've been sick, fat emboli if they've had a recent long bone surgery like a femur surgery. You can shoot fat from the cortex of the bone to the lungs, or if they're pregnant, you can have an amniotic fluid embolism as well. Usually, this is where the timing that we talked about earlier comes into play. These are sudden onset, chest pain or shortness of breath. I was fine, I have no lung problems, and like that, all of a sudden I had an issue. They're usually pretty tachypnic and tachycardic. So when you think about risk factors, there is a scoring system that we use in the ER called the PERC rule, PERC. Basically, it says, has this patient had a recent long distance travel, long flight, long car ride across the country? All right, well, you're stagnant for a long period of time. Yeah, you could have a clot. Recent surgery, impaired mobility, same reason. You're stagnant, you could have a clot. Hormone replacement therapy or birth control, it causes you to be more thrombotic. You're more prone to form clots. Fat people are more prone to form clots. If you smoke or if you have cancer, you're more prone to form clots. So if they have these symptoms and some of these risk factors, maybe you got a PE. And especially, I didn't put up there, but if you have one leg that's swollen and the other one isn't, that's a giveaway. That's probably a DVT that broke off and now shot to their lungs. The reason we say that, and it's good to know, is it probably a PE? I'm going to probably move those fairly gently, because if you've got this kind of restricted flow through the lungs, dadgummit. If you got this kind of restricted flow through the lungs, but there is some flow, I want to move them gently. I don't want to jostle them around, because if for whatever reason you dislodge some of this clot, and it wouldn't necessarily be your fault, they're in a bad way to start with, but if you move them aggressively and you dislodge one of these clots, and now instead of a little bit of blood flow, there's no blood flow going through, like this saddle actually blocks everything, they're dead. You're not going to bring them back. The only thing that brings them back is thrombolysis, and even then in this, probably not going to work. That's our Hail Mary when we have a blood clot that codes in the ER. Anybody recognize this? It's an EKG pattern.
That's the S1.
That is. Yep. So if you see this, they've got concern for a PE. This doesn't mean they have one, but this is an indication that it might be there. Okay? So S1, Q3, T3. You have a deep S wave in lead 1. You've got a Q wave in lead 3 with an inverted T wave in lead 3. That's a pulmonary strain pattern, or a right heart strain pattern. That doesn't have to be a PE, but when I see that, so if somebody brings me something, we sign a bunch of EKGs all day. If somebody has just walked in the front, they did an EKG, and they tell me, hey, this guy's here for chest pain and shortness of breath, and I see that, I'm worried that they've got a PE. We probably need to get them back sooner rather than later, not sit them outside for the next 8 hours. Okay? So just something to think about. Yep.
So that's a right bundle branch pattern, right, Doc?
Mm-hmm.
So the key there is the septum's been stretched, you have a different rate of conduction, and the going down the septum, that's what's causing that EKG pattern.
Correct. You're exactly right. That heart strain is due to it's having a pump against a blood clot sitting in the lungs, so that right heart is getting stretched. You're right. The forward flow is not as good. Okay. Then spontaneous pneumothorax. Y'all know how to fix a pneumothorax. That's easy. If it's tension, put a needle in their chest. If it's not, let's watch them until I got to put a needle in their chest. But I just mentioned this because if you've got a really tall, skinny person that all of a sudden says, yeah, I had sudden onset chest pain and shortness of breath, I would listen to their lungs. They are more likely to have a spontaneous pneumothorax. They can simply be walking from here to the door and their lungs pop. And it's just by nature of they're so tall, it actually stretches their lung parenchyma just a little bit and more prone to have a rupture. Okay. It's hard to see, but this is a very tall, skinny person. As you can see, not a lot of fat, but there's no lung here. This is their lung now. So this, when you see a bunch of these airways, that lung's fully inflated. This is a bunch of air, no lung inflation. That's the lung right there. That person's got a tension. They're going to have the tension physiology of tachycardia, chest pain, shortness of breath. They're probably going to have some hypoxia and blood pressure issues, which is your indication that we're going to put a needle on. Okay. Your needle thoracostomy, remember it's mid-clavicular line, second, third intercostal space, or mid to anterior axillary line, fourth and fifth intercostal space, which is nipple line, anatomical nipple line. Stress that part. Anatomical, where it's supposed to have been. Okay. And that's it. Any questions? I know there's a lot of anatomy, but the treatment's the treatment for most of them. It wheezes, give them some albuterol, but not all that wheezes is asthma. So think for other things like obstructions.
What do you say, what'd you call that? The EKG?
S1, Q3, T3.
You said, what about the Q wave?
Yeah. So it is in lead 3, you got a deep Q wave right here. Yep, and inverted T in 3. Again, non-specific, but it's there. It's just another clue.
Hey, Doc, we had one question come in. What about waveform capnography changes for emphysema, chronic bronchitis? So we all know about the sharp thinning pattern for asthma. Would we see the same thing for emphysema?
Yes, to a point. If so, emphysema specifically, COPD you would, because it's an obstructive process, just like asthma is. Emphysema, you would still see it to a point. It's more of an air trapping, so you won't see quite as much of the shark finning. But you will see that pattern where it's not just a smooth rise, plateau, fall. The waveform will be a little bit different. It'll mirror a little bit closer to that shark fin, but it won't be the true shark fin because it's not as much of an obstructive pathway.
And also we had, Dr. Ferguson texted me just, making the point that Atrovent, which is a combination of albuterol and ipratropium, antagonizes acetylcholine, so you get reduced mucus production as well as bronchodilation. No risk for additional doses, he adds.
Yeah.
Max effectiveness is 3 doses. All right, got any other questions in the group here? If not, we'll wrap it up. Thanks to everybody online for attending today. Remember to fill out the form, so you get credit, so that we know you attended. You can send an email to alabamaemschallenge@gmail.com to get an automated reply with a link to the attendance form, or click the link in your chat box. 2 weeks from now, we'll be in Mobile for Alabama EMS Challenge, which will include an afternoon skills lab if you have to be in that part of the state. 2 weeks from today, please join us. We'll be at the Mobile Convention Center. That'll be hosted by Mobile Fire Department. And as always, we are sponsored by the Alabama Fire College, and we appreciate their sponsorship. Thanks everybody for participating. We'll see you next time.